All right, welcome to your fluids lecture. You'll have a separate one just on electrolytes. So the standards for this portion of the lecture are going to be similar to the ones that are on the electrolyte lecture. So we're going to describe the restoration needs, interpret lab data, risk factors, priority interventions, and distinguish between the manifestations of each one of these imbalances, and then education and collaboration about taking care of these type of clients. So first we need to talk about body fluid compartments. So just because there's extra or not enough fluid in a certain area, we need to know what kind of areas we have as options because that determines what type of imbalance we have. So first, body fluid comes from either an intracellular or an extracellular space or compartment. In the intracellular area, we have fluids that are within the cell, and this takes about 2/3 of the body's water amount. The other third of the body's water comes from extracellular body fluid compartments. So these are the fluids that are outside of the cell, and this consists of intravascular, interstitial, and transcellular types of fluid. So this is only 1/3 of the body fluid that is actually in our bodies. But that 1/3 is practically what we're talking about with most of these imbalances. But where is the fluid shifting? So balance of these compartments is going to be maintained through our intake and output sources, controlled by hormones and filtration systems, most definitely, especially the kidneys for output. So intake, measurable intake are like oral fluids, parenteral fluids, enemas, and irrigation that may be happening. But non-measurable intake, like solid foods. So if we eat an apple, there's technically fluids that are in the apple, but we can't really measure the amount of fluid that we're getting from our foods, as well as with metabolism. So that's not really a measurable intake, but it is not negligent. Input can then be affected by our thirst sensation, which is again controlled by hormones. And then we have social factors and personal habits that can affect how much input we put in our body. Then we have measurable output and non-measurable output. This is most commonly urine, emesis, feces, or any drainage, like from wounds. So we need to know that a minimum urine output per day is 400 to 600 milliliters. So if they are not putting out at least that much urine in a day, they are considered oliguric, so the minimal output, and they are at risk for fluid balance. Then non-measurable output, like when we perspire, any kind of vaporization that can happen, and also like insensible water loss. So this is, again, not really able to measure, but it is something that we need to be aware of because the combination of these factors can contribute to 500 to 1,000 milliliters a day that we are getting rid of. So of course, if someone is exercising more, that perspiration may be up towards the higher end or more. Whereas if they're not, then we might be more towards the 500 area. And again, output is mostly affected by the kidneys, but there are other organs that are involved. So first, let's talk about fluid deficit. Fluid deficit kind of has two different realms. Fluid deficit is related to a fluid intake that is less than the client's needs, resulting in a deficit of fluid volume. Then we have, in that category, we have hypovolemia and dehydration. Hypovolemia is when the circulating volume is decreased in which decreases perfusion related to vasoconstriction and thereby increases peripheral resistance in order to maintain blood pressure and circulation, versus dehydration, which is the lack of fluid due to insufficient intake or excessive loss. So there's different types here of fluid deficit. Dehydration can occur due to water loss or electrolyte loss. If it's due to an electrolyte loss, this is considered isotonic dehydration because it's self. This can be from a prolonged fever, hyperventilation, diuresis, excess salt, or hypertonic fluid intake. Whereas hypovolemia can occur with heavy or prolonged physical activity, living in dry climates or high altitudes, and caffeine and alcohol can also contribute to hypovolemia. So the circulating volume has been decreased versus there is a lack of intake of fluid. So there can be different reasons for these, but both of these are considered a fluid deficit. So fluid deficits are pretty much going to look very similar. There's one or two minor differences to take note of. On assessment, we may find like a weakened, thready peripheral pulse. It may be difficult to find and can be easily blocked because it is so weak of a pulsation. The neck and hand veins are going to be flat, regardless of positioning. So usually they're supposed to be pretty bounding and elevated, but regardless of any position that we put these clients in, especially in severe cases, they are never going to have bulging veins. They are just going to be flat veins. Skin turgor, we're going to see tinting or delay of return back of the skin turgor. Dry mucous membranes, it may be also covered with a thick, sticky coating. They may have cracks or fissures, and their tongue may be dry and furrowed. Changes in neurostatus because of reduced perfusion to the brain can occur, and then can also progress to the point of seizures, especially when there is an electrolyte change along with the fluid loss or fluid deficit, I should say. So water usually follows sodium or vice versa. So we'll talk about sodium deficiencies in the electrolyte lecture and why this happens with this type of fluid deficit. Nausea, vomiting, anorexia, and then weight loss can also occur. We have a diminished capillary refill and cool, clammy skin, diaphoresis, and sunken eyes. Vital signs, they're going to have an increase in heart rate, which is a mechanism trying to maintain their blood pressure, but their blood pressure may decrease with a decrease in pulse pressure, especially in cases that they have orthostatic hypotension. They can have an increased respiratory rate, which is another compensation due to reduction in perfusion and gas exchange, trying to increase that oxygen delivery. And they may even have a low-grade temperature. This is the body's, again, another compensating mechanism to try and increase their rate of retaining water and maintain vitals, essentially. Lab-wise, hematocrit is going to be increased in cases of hypovolemia, but not necessarily in dehydration. So there is a difference there. Whereas with osmolality, you're going to have an increase of greater than 295 milliosmoles per kilo with dehydration, but not with hypovolemia. In both cases, a BUN is going to be increased. Urine-specific gravity is going to be increased, and sodium is going to be also increased due to the dilutional effect. So if water is gone, then what is left over in concentration-wise per milliliter of fluid, the electrolytes didn't leave. Also, they are then in concentration an increased amount ratio. So be mindful of that when we're going into the electrolyte lecture. Treatment, these clients will need to replace their fluids. First, we're going to start with oral replacement therapy. So asking them in education about maintaining an oral intake of at least 1.5 milliliters a day, or at least 500 milliliters more than their output. So we have already assessed them, we acknowledge and diagnose and tell them that you probably have some fluid volume deficit. You probably are dehydrated. So over the next few days, try to drink more than you're peeing, essentially, so that you are not just maintaining where you're at, which right where you're at is in a dehydrated state. We want you to no longer be dehydrated or hypovolemic, so we need you to take in more than you're putting out. IV fluids we may have to progress to, or in the severe cases, start with. And this is going to be based on how much weight loss that the client has had in this fluid deficit state. We are going to do IV fluid boluses of 500 milliliters per Celsius increase in temperature also. So they already are getting IV fluid boluses, but if they also have a low-grade temperature increase per 1 degree Celsius, we're going to add another 500 milliliters of fluids. This is because of the temperature increase that can increase the metabolism, and thereby you have more insensible water loss, which remember can be at least 500 milliliters a day. So this is trying to compensate for that additional water loss. We may have to also prescribe or give them some antidiuretics, antiemetics, or desmopressin, depending on the cause of the hypovolemia or dehydrated state. So if they've gotten to this point because of severe diarrhea, we're going to give them antidiarrheal. Is everyone getting an antidiarrheal? Not necessarily. But this is more treating the cause of their fluid loss. So our goals for treatment for these clients are going to be to maintain a urinary output of that minimum of 400 to 600 per day, hopefully more. And ideally, however much their intake they're getting out as an output. So maintaining that urinary output, making sure that their kidneys are still properly functioning, improving their specific gravity of their urine, and preventing any falls, especially due to that neurostatus changes. Now, complication that can occur if this is caught too late, treated too late, or what have you, hypovolemic shock can occur. This is when the mean arterial pressure decreases, which slows perfusion even more to tissues, and thereby slowing down perfusion, we're not getting oxygenated. So one of the main things here we're going to start with treatment-wise is going to apply oxygen to them. Vital signs every 15 minutes because that blood pressure and heart rate can change drastically in very short period of time. Fluid replacement, of course, in this case, definitely IV. We may also need to give them a vasoconstrictor, so like Levophed or something that can increase their blood pressure and cause that constriction so that they can perfuse better. We want to improve myocardial perfusion, so we may use some cardiac medications here and some positive inotropics for that same reason. Get oxygen back to the heart as well. So now we come to fluid excess. Fluid excess is where body fluid, fluid intake or retention is greater than the client's needs. This can also occur with hemodilution, and so need to be mindful of the components that are in the blood flow, such as the red blood cells, hemoglobin, things like that, are going to be affected in this case severely. We have then overhydration and hypervolemia. With overhydration, we have too much fluid in the body, such as with excessive water intake, either if it's forced, they're drinking just way too much water, or they have polydipsia. They can have syndrome of inappropriate antidiuretic hormone. They may have excessive D5W IV fluids, or hypotonic irrigation can also occur with this, can cause this. So there's just too much fluid in the body from some other source. Whereas hypervolemia is an excess of water and electrolytes in the right proportions. So this can happen with compromised regulatory organs, like the kidneys, overdose of fluids, fluid shift from burns, just like when we talked about with cell death from blood transfusions, cell death releases that bilirubin and causes that jaundice appearance in some of our reactions. But also when cells die, they release potassium, so and fluid. So it's going to push that fluid to a different compartment. So this is a very high indication that they may actually get overhydration or fluid volume excess as a result from burns. But when we treat burns, we'll talk about later, one of our treatments is to give them a bunch of IV fluids. But it's important to give them the right kind of fluids, because the balance of the IV fluids, hypertonic, hypotonic, isotonic, which we'll talk about shortly, will help shift that water from one compartment to the other compartment for our goal. So that is what can happen with burns. And then prolonged corticosteroids, severe stress, and hyperaldosteronism are also risk factors for hypervolemia. So with assessment and everything between these two, they are very similar again, but minor differences. So on assessment, fluid volume excess clients are going to have a bounding pulse, which is opposite, an increase in central venous pressure. Remember, we just have excessive circulating volume in most of these cases. So weakness, visual changes, paresthesias, altered consciousness, and seizures can also occur. So this is actually getting in the same realm as the hypovolemic. So we've got a little overlap in our symptoms here. So knowing your additional symptoms, such as your other assessment items and vitals, are going to help you differentiate between these two types. These clients may have ascites, increased motility, liver enlargement, crackles on their lungs, cough, dyspnea, because that fluid is being pressured into the lung field, so that you'll hear fluid on their lungs. Peripheral edema and weight gain, which is also due to third spacing from this excess fluid volume being pushed out the vascular system to wherever it will go. Distended neck veins, because we have just so much fluid, don't know what to do with, pushing on our veins. As a result, our kidneys, if they're working, are going to kick out extra urine, so we're going to have an increase in urinary output, and their skin may be cool and pale. Vital signs, we're going to have an increase in heart rate, blood pressure, and respiratory rate. In labs, we are going to have a decreased hematocrit and hemoglobin, decreased blood osmolarity with fluid volume excess only. We have decreased urine sodium and specific gravity. We have a decreased BUN due to the plasma dilution from the blood compartments. And then on chest x-ray, sometimes we can see that pulmonary congestion. Treatment-wise, we're going to restrict fluids. Sometimes this can be a little difficult because, yes, they have extra fluid, but the compartment that it's in, such as peripheral edema in their lungs, but intravascularly, they may be underhydrated. or not have such a bounding pulse and things like that because it's already shifted to those areas. But we still need to do fluid restrictions to prevent the body from shunting that fluid again. Monitoring their daily weight and intake and output is going to be critical in these clients. Any kilogram change in weight is equivalent to 1 liter of fluid. So be mindful of this calculation or equivalency. So if a client has gained a kilo in a day, you need to be going back to your assessment and finding out where that potential 1 liter of fluid is hiding in that body. We're going to do a sodium restricted diet. May need to put them in a semi-Fowler's or Fowler's position just to help with their breathing, and consulting respiratory services to help also with that pulmonary congestion. Our complication here is going to be pulmonary edema. And so they may develop anxiety, tachycardia, increased vein distension. They may have PVCs, premature ventricular contractions. They are going to have dyspnea at rest, change in level of consciousness, maybe restless, lethargic, and ascending crackles. So the crackles are going to start at the base because of gravity. The fluid is at the bottom, the base of the lung, and it's going to ascend. It's going to increase as it starts to fill up. So being mindful of that potential change and listening to those lung sounds, not just once a shift, but frequently so you can tell if it's ascending or not. Making sure that they are in a high Fowler's position or orthopneic position so that they can breathe a little bit easier. Oxygen may be needed. Positive airway pressure and intubation may have to be resorted to as well. Medication-wise, morphine can help with their pain and anxiety, and also the increased the increased demand on the cardiac muscle. And so helping the cardiac muscle slow down, kind of take a breath, breather, and relax, and therefore being perfused again. It's also a vasodilator in some of our vessels, the large vessels especially. So that's what I mean by relaxing and taking a breather. They're relaxing and opening up. So then opening up that perfusion and hopefully being able to help remove that fluid backwards. Nitrates also vasodilator, so it helps with the same reason. And then diuretics to pull that fluid off, but only in cases that the client's blood pressure is maintained or stable. So being mindful when we use diuretics, especially aggressively, that their blood pressure is tolerating it when we're pulling that fluid off. Now, when we talk about using fluids, osmolality of IV fluids is also important to know. What type of fluids are what type of solution? So isotonic, meaning being same. So these fluids are very similar to the composition of your blood components. And so it's not going to change any cellular things to cross through. So giving these isotonic type of solutions like normal saline, D5W, D5 quarter normal saline, and LR are going to stay in the intravascular space when it being administered. They are not going to cause a fluid shift. Now, in the cases of hypotonic and hypertonic, they will cause a fluid shift. Hypotonic is because in the concentration of what's in it is low. So we have half normal saline is considered, if normal saline is normal, then half normal saline is in a low concentration, therefore it is the hypotonic version of fluids. What happens when, with cells, things like to go from a high concentration to a low concentration, right? So if we fill up the intravascular space with a low concentration fluid, what's that going to do? It's going to pull the concentration of those electrolytes in that fluid from the cells back into the space, but it doesn't really need much fluid. So it's mostly going to pull the electrolytes. And in that case, hopefully then we will have a balance of our fluid and electrolytes again. So the opposite is with the hypertonic solution. So in concentration, these fluids are high concentrations of something. So D10W, 10% dextrose in water, is more concentrated than D5W. So D5W is considered a normal solution. D10 is in a higher concentration, so it is hypertonic. Then you have D5 normal saline, D5 half normal saline, and D5LR. Okay, so these are options that we will give to move that intracellular, extracellular balance again. So if we were to administer this IV fluid to the intravascular space of a high concentration, doesn't really need fluids anymore. What's it going to do to the electrolytes is push from high intravascular into the cells where the low concentration is, and thereby hopefully balance again. So we need to know what kind of fluid volume excess or electrolyte deficit, fluid volume deficit that we are in to make sure that we are using an appropriate type of fluid. So this is going to be very important for you to know and understand the relationship of going from high concentration to low concentration, and thereby memorizing which ones are normal to help you figure out which ones then are higher or lower for hyper and hypertonic types of solutions. So these are the resources from your textbooks in IGGI, ATI MedSurg, as well as ATI Nutrition. That's going to be more I'm going to pull for the electrolyte chapter. So make sure that you also listen to the lecture for the electrolytes that I am finishing up and will post shortly after this. Thank you, and I'll talk to you in class.